So, good morning, everyone. Let's start without wasting the time. So, I myself, Dr. Munjal Pandya. So, we'll going to discuss excellent MCQ today. You will definitely enjoy, uh, no doubt. So, for those new students, quickly rehash about the medical MCQ for all. So, medical MCQ for all is a basically a coaching company exclusively also provide the study material and various things which needs to crack your prometric exams DHA, HAD, MOHO, MSB. Lot of questions what we provide, so I'm going once again very quickly. We provide prometric 1000 MCQ hard copy book as well as ebook. We also recently launched, so those who have access they can use the online as well as offline hard copy as well as electronic copy. Online subscription and coaching is one of the best specialty from our team. There are a lot of provider who is providing the subscriptions blah blah, but this is all by the experts, not by subject as experts. So I'll discuss with you WhatsApp subscription. We are exclusive player in the market for providing the Oman viva with good success rate. So not just the Oman subscription but Oman viva coaching as well. Exactly how you gonna do in Oman viva will guide you. Data flow services for all specialty nursing, dental, physio, specialist, super specialist, GP, all. We also have one of the excellent package which called as the short package, especially designed for second and third trial doctors. I mean those who have like critical, mainly the third trial, guaranteed pass. So this is short. We have a mobile application on Android. So those you are using Android phone, you can download the same name, medical MCQ for all, that is there. If somebody needs the link, just do let me know. I will share the link as well after my class in the group. iPhone as well, we have a mobile application. So complete whole website with all the mock tests, practice paper, recalls you can access from your mobile phone. And recently we started the dedicated mock test. So you can give unlimited mock test on our website, right? So this is the basic thing. So almost I can say all in all, we provide a complete study material, subscriptions, book, coachings, everything for the students. This is myself, Dr. Munjal Pandya. I'm hemato-oncologist and bone marrow transplant fellow, practicing almost for more than 20 years now. And this is all my accreditation, so no need to go in much detail. I did my fellowship in hemato-oncology and transplant from Italy, Rome. I did my fellowship from North Sydney and practicing for more than close to 20 years and teaching and coaching experience of more than 10 years now. And I'm member of American Society of Clinical Oncology as well as Indian Medical Association. This is Dr. Aarti. Those who are new, she is a consultant pediatrician regularly taking the classes for pediatric. Excellent speaker, Dr. Medi. You must be enjoying the ECG class. She had taken wonderful ECG class yesterday. She is an internal medicine doctor, Dr. Medi. She is also in our team full time, Dr. Shikha. She is a consultant gynecologist based at recently shifted to Dubai 3 months back. In our team, she is taking regular gynec lecture for exclusive gynecology. She is right now in Dubai. Dr. Deepal is also in our panel, so we are updating her profile. She is also consultant gynecologist taking lecture. He is Dr. Ankit, he is a gastroenterologist, he is also in our team. And Dr. Anjali, then Pallavi and Meghna, and there are a lot of team and IT team. So this is just for your the introductions. This is our contact details. This is our book, ProMetric 1000 MCQ book, which we recently launched in February, March somewhere. It is a compilation of 1000 MCQ with the answers, most with explanations as well, right? So those who are fond of books, and I'm just for your knowledge, 20th of September means after 5 days, I'm flying to Dubai for 2 weeks at least. Those who need the book, I mean, probably they can get at much discounted rate. I'm coming with some books as well. So, so those who are interested in getting the book, right, they can place the order as well. So I can come with the book as well. It would be much cost effective, right? We have a coachings as well, various module with discounted rates. So you can talk to Dr. This Anjali, or you can also talk to Pallavi as well. So almost 70% cost reduced in the combo package, almost 70%, which gives you complete. You get book, website, coaching, subscription, nothing is left. So That is very interesting. And Dr. Anjali is head of data flow. She is dealing with data flow, license transfer, right? As well as exam booking, some document problem. So you can contact. She is based at Dubai as well. So our UAE number and Indian number both are there. So you can call or contact on either of this number. And we are recently coming up with the more modules of mock test as well as few other things for dental. We are also coming up with a new course of dental and EMRI as well. EMRI is a new course we are launching somewhere in end of the September. Emirat Medical Residency Entrance Exam, shortly known as EMRI, right? So EMRI we are launching by this month end. So stay connected. Those who wants to get more information on EMRI or residency program in Dubai, they can meet me as well in UAE after 20th of this month, means after 4 or 5 days, right? So let's start our mock test. This is the general informations. Everyone gets ready, and this is all interactive. I wish everyone get the answer, right? These are, I mean, absolutely high yield, and we'll discuss it properly, right? So first questions in front of your screen. A 67-year-old woman is admitted to accident and emergency with a pyrexia of 38.1 degrees Celsius and a cough productive of green sputum. The observation shows that the pulse rate of 101 per minute, BP 80 by 60, respiratory rate is 32. Patient woman is alert, oriented with time and space. Blood culture reveals WBC blood result, sorry, reveals a WBC of 21,000, urea 8.5, chest X-ray shows patch of the consolidation in the zone, right lower zone of the lung. She is treated for severe community acquired pneumonia. Which of the following is correct calculated CURB 65 score for her? Is it the score is 68429? So your time starts now, right? You think over it. I'll give you a few tips to you as well. Meanwhile, you are answering. For those new students, whenever you answer any questions, any exams of MCQ, you need to have a triad of three things. One, you must know the diagnosis, you must know the investigation, you must know the treatment. So those who can interact with me this question, I'm interested morely in these three things, right? So you can post your answer in the chat box. We have a chat box. You can post your answer in the chat box. Yes, Dr. Radia. So let's start with you today, if you don't mind. You can unmute your mic and tell me how you count this score. Dr.
Good
Radia,
morning, sir.
very good morning. Are you okay, comfortable discussing with me?
Yes, sir.
Wonderful. So go ahead now. First of all, what is the CURB 65 score? I'm going to
Sir, I
discuss
don't
lots of
know.
questions. Sorry.
Sir, I don't know. Good morning.
Good morning. No problem. We'll discuss. So let's Radia to finish, right? Then we'll come to you, Dania. Yes, Radia, tell me. So how you calculate this score, CUP 65?
Top 65 score, it is used um, to decide the management of community acquired pneumonia. And the CURB 65 stands for C stands for confusion,
Yes, go ahead. Wonderful,
U for uremia,
right?
R is respiratory rate, B is for BP, and 65 is age greater than 65.
Wonderful. So now how you calculate for this patient? I'll get back to again the questions, right? So you tell
Here
me
the
one by one.
Here the patient is alert and oriented in space and time. So C is not there, and urea is cutoff value is 7. Here it is 8.5. Score is 1, and a respiratory rate cutoff is 30. Here it is 32. So we have 1 point. BP, I think systolic less than 90. Here it is 80/60, so we get one more score, and the age is 67.
Excellent, Dr. Radhi. Excellent. So this is
Thank you,
what
sir.
the thing. So those who are new, those who never know the CUP 65, so basically CUP 65 criteria is applied mainly for the community acquired pneumonia. So they have already given the diagnosis. They have a community acquired pneumonia. How? What are the point favoring the community acquired pneumonia? You must know. You don't need to just mug up. If you learn the technique today, I can guarantee nobody will fail. 100% result. You need to know the three things. So diagnosis, community acquired pneumonia. First is a fever, right? Another thing is a productive cough. Second thing. Third thing, patient because of pneumonia, he has a fever, he has hypotension, maybe probably in the shock, maybe septic shock, right? Also, WBC counts are high, right? Also, renal functions are altered. So probably this is classical septicemia, and X-ray also shows the consolidation. So he is a classical case of community acquired pneumonia. Whenever any community acquired pneumonia comes, whether in the exam or in the practice, so tomorrow morning you are going to the ICU, one patient is admitted who is diagnosed as a community acquired pneumonia. So another those who don't know community acquired pneumonia and hospital acquired pneumonia, you must know the difference, right? So this is homework for you just to save the time. How you differentiate community acquired pneumonia and hospital? So biggest difference is community acquired pneumonia develop in the community, right? And hospital acquired pneumonia develop within the hospital. So say for example, patient is admitted today on the day of 15th of September, right? Patient is fine. He has no pneumonia. He had admitted for the appendix, example, acute appendicitis. And after 3 days, means 18th of the September, after 3 days, he developed fever, cough, temperature, tachycardia, hypotension, consolidation on the chest X-ray, which was not there at the time of hospitalization. But after hospitalization, he developed something wrong in the pneumonia. That is literally mean of hospital acquired pneumonia. After patient entered into the hospital premises, he developed pneumonia. That is hospital acquired pneumonia. It won't develop in 12 hours.
Nosocomial.
It usually, right? It develops usually after 2 to 3 days of the hospital, right? This is the most important. So we'll discuss later on. Let's come to the curve. So those patients who have community acquired pneumonia, you must apply each and every patient. Why it is important? Because it directly relate with the mortality. It has a mortality. So every whatever the each, there are five factors: CURB, confusion, uremia, respiratory rate, BP, age more than 60. If any point is there, score one, right? If no point is there, so confusion is not there. Why? Because he is a conscious, well oriented, so there is no confusion. That is why zero. Uremia more than 7 is 1 point, it is 8.5. Respiratory rate is more than 30, it is 32, so 1 point, right? If it is less than 30, then it is zero, right? Blood pressure is less than 90 systolic, here 80, so score 1. If it is 100 systolic blood pressure, then it is 0. Age more than 65, 1, so 1, 2, 3, 4. So 4 point is very high, and it some patient it could be 5, right? Because confusion is also there. So maximum point is 5, minimum is 0, right? So 0, 0, 1 is good, 2 to 3 is moderate, and 4, 5 is a very bad. So I'll come to the literature. So this is COP 65, as I told you, confusion 1 point, uremia 1 point, respiratory rate 1 point, this 1 point, 1 point. So our patient does not have this. So out of 5, we have 4 parameters present. So our score is 4. What is the importance of the CUP 65 score? 0 to 1 is a risk category or mild or 30 days mortality. After admission, 30 days, how many people will die? Hardly one people. Low risk, it considered as a low risk, right? And you can treat in an outpatient department. You don't need to admit every pneumonia in the hospital. When the patient's CUP score is low, when patient is stable, patient don't have much complaint, you don't need to admit each and every patient of the pneumonia. Score 2 depends, you use your clinical judgment. If patient is stable, vitals are stable, up, definitely the mortality is almost 5 to 10 times more, right? 1% to almost 9%. And probable admission, it's not always like patient is stable, you just observe. So it's your clinical judgment. OPD means outpatient versus indoor IPD patient, and 3 or 5. So 3 or 4 or 5, they are high risk. So mild, moderate, severe. Higher the number, bad the prognosis. Mortality 1.5%, here close to 9-10%, 22%, close to 25. So 1 in 4 patient will die if they have score of 3, 4, or 5. Admission is definitely mandatory and managed as per the pneumonia culture. You do the culture, sputum culture, depends on the organism, you can treat this patient. So it is extremely important, and leading cause of death across the globe. You go and read the WHO, any country in this world, pneumonia is in top 10, right? Top 10 leading cause of death, pneumonia, top 10 in pediatric, adult, immunocompromised, as well as old age. So you never ever miss the curve 65. So you make a fix a mindset now onwards. Whenever any community acquired pneumonia patient comes to you, right, you should ask for you should check for your patient, right? What the score your patient has, right? So depends on that you can assess the mortality risk, as well as you can also assess whether to admit or not, because mild you can treat outpatient, moderate severe you indoor the patient, right? So this is how it works, right? So what they are asking here, right, which of the following is a correct calculated curve 65? So answer is a 4, right? Because high 6 is not there. So if you have logic, 5 things, so 6 is not there, 8 is not there, 9 is not there. So you just need to decide between 2 and 4, right? Because 6, 8, and 9 score is all not there in the picture, right? Because maximum score is 5. So anything more than 5 is gone. So just to confuse you, I kept 6, 8, and 9. Right? Is that clear? And any questions to anyone? Any questions to anyone? Which is the treatment, Radia? What is the commonest organism for community acquired pneumonia? What is the commonest organism community acquired pneumonia? Anyone? So if we are talking about community acquired
Legionella.
pneumonia, right?
So
I think
Streptococcus
so.
But
pneumoniae.
right, so there are
Legionella.
Streptococcus pneumoniae.
organisms. So it could be different from
Legionella.
different, right? So this is the homework. You need to do little hard work as well. So community acquired pneumonia, in every community it could be different. In USA it could be different, India could be different, Middle East it could be different. But in general, you should know, number one, as a part of homework, what this is the exam questions. I am completely discussing 10 question in one question. So organism you must know, and treatment. Treatment. So our triad is there. Diagnosis is community acquired pneumonia, investigation of community acquired pneumonia by history, examinations, right? Chest x-ray, sputum, right? You diagnose that, okay, fine, this is community, and you need to know the treatment as well. So that is what your homework is. So you go and read it just to save the time as well, and to have little more homework. Otherwise, you won't do it, right? So this is what the thing. And another questions, right? In the same pneumonia, you need to know difference between typical pneumonia and atypical pneumonia. Typical and atypical, right? This is also very important. Typical versus atypical pneumonia. So how is the presentation? What is the organism, right? And how you differentiate between typical versus atypical pneumonia. That is very well given in Master the Board. So do some exercise, try to do this, right? So we'll just jump to the next question. These are the two your homework. This will come definitely in exam, so don't ignore it. Let me first catch the next question, then I'll come to this. This question is front of your screen. A 55-year, right? Age is extremely important in every MCQ. So never ever ignore the age, right? Because it is sometime a decision maker. So 55 years old postmenopausal female came to you with a painless upper outer quadrant of breast mass, hard in feel with no axillary palpable nodule. Bilateral mammogram was done, which shows the below picture. You have the picture of mammogram. I got it from the internet. Excellent picture. Something wrong you are seeing in upper outer. This is a lateral view, right? So something wrong you see here, right, in the breast, in the picture. What is the best initial next step in the management? Are you going to do true cut biopsy? Are you going to do FNSE? Are you going to do PET CT scan for this patient? MRI is okay for this patient, and you are going to do the bone scan as a part of the staging workup. So what exactly you want to do? Yes, Dr. Preeti, I would like to get answer from you. You answered the B, right? So what, how you explain this? Yes, Preeti. Okay, you are unable to speak. Excellent, no problem. I got it. So let me check with Dr. Dania. Can you explain me why you selected FNSE, Dania? Now you can open up your mic. You can unmute. You have bottom on the computer facility to unmute the mic. Yes, Dr. Naveen, would you like to comment anything on this?
Yes. So any breast lump, you have to do triple assessment. Of course, clinical examination might have done, and I've done organized imaging, which is mammography. Suspected lesion is there. Next, I would
Fine.
be going for
So
biopsy,
what do
like
you first for other students for better clarity? What do you mean by triple assessment?
so any breast lump,
Okay.
we have to do three things. One is clinical examination. The triple assessment include clinical examination,
Wonderful. What else? Second thing?
and image studying, for example, ultrasound or mammogram in this case.
Okay.
And the next one would be biopsy, like
Okay.
FNAC
Okay.
in this case.
Okay. So FNSC or biopsy, or both are the same thing?
Fine needle aspiration now in this case of a for cytology.
Okay. So you don't want to go for true cut biopsy?
I would choose FNSC.
Okay. Fair enough. Fair enough. Right. So is there any advantage of FNSC over true cut biopsy? Multiple question with the breast lump, multiple in the exam. Hundreds. We can speak whole the day. We can take one mock test of breast only.
When
whole
I
day.
was working in onco department, I still remember the doctor did punch biopsy, one of the blood for breast lesion.
Punch biopsy. So
Yeah.
biopsy is different from FNSC. Na? So what you
Yes,
want to do now? So in exam, what's your answer? Don't confuse. You stick to your answer. I'm trying to confuse you, but you don't get confused. This is an absolute excellent debatable discussion. I mean, platform. So what you will do, or how you decide, or what's your things?
I want to do biopsy.
Okay, biopsy. So you change your answer from FNSS to true cut biopsy.
Yeah.
Okay, fine. So what are the advantage and disadvantage of true cut biopsy versus FNSC? Let's discuss because it's extremely important. Highest number of female dying across the globe is from breast cancer. So I request and urge 100 absolutely read each and everything about the breast cancer. Breast cancer, everything you should know, whether they ask in the exam or not, because you can save the life of your family, friends, our near and dear, and your neighbors as well. So you must know. If you don't know, you cannot advise the patient. So FNAC is a fine needle aspiration cytology and biopsy. There are various type of true cut biopsy, right? True cut biopsy, incisional biopsy, excisional biopsy, right? So there are a lot of things, but anyway, it's a biopsy. So FNAC, what are the advantage? Here the advantage, and we know the disadvantage. So advantage of FNAC, it is easy to do. Number one, this is the biggest advantage, right? No expertise is required. I mean, anybody can, even you can do the FNAC. What is FNAC? Say, for example, this is a breast, right? This is a breast, and lump is here. So you take one syringe, right? There is a needle, you enter the needle, right? And this is a syringe, just my drawing, just for understanding. So you enter one needle, right, with the syringe, take a fluid from, make it on, spread it on the slides, right, and you see under the microscope. This is FNIC. Very easy, very doable, right? It is very doable. So anybody can do it. And mainly in a remote area, village area where the surgeon is not available, periphery, we can say periphery. So at least if somebody suspected of breast lung, probably malignant tumor, they do the biopsy. So these are advantage. It is easy to do, no expertise, periphery, means non-expert can also do, who is not very trained in biopsy, right? And it is a easy readable, right? Anybody, any patho, it doesn't require the super expertise or hematopathologist or expert histopathologist to read. Even reasonable histopathologist can read this slide, and it is cost effective as well. Cost effective as well. So these all are the advantage. What is the biggest disadvantage is sensitivity and specificity is low. Sensitivity and specificity is very low compared with biopsy. So biopsy, biggest advantage of biopsy is sensitivity and specificity is very high in general. Here, why it is low? Because here you are trying to find out one cell from 10,000 cells. Say for example, one abnormal cell from 10,000 cell, and here you are finding one abnormal cell from 1 lakh or 100,000, right? So by seeing lots of cell, you are also less chance you that miss even one cell, right? So biopsy is extremely important, more important. Here it is little difficult. Disadvantage of biopsy is little difficult. Expert is required because they should know the true cut. Usually in periphery it cannot be done. Even reading is required and it is more costlier than FNSC. But the biggest here the disadvantage, here the advantage. So biggest advantage is the accuracy of the result, and that is why we should prefer the biopsy first. And one another test which you cannot do on breast suspected cancer, ERPR and HER2, estrogen receptor, progesterone receptor, HER2 new receptor, can be done only and only on the biopsy, not on the FNSC, because it's a liquid. So on liquid you cannot do ERPR here. This is a hardcore true cut biopsy. So here you are getting the piece of the mass, breast mass, right? So it's a solid, it is a liquid. You cannot do on liquid, you cannot perform ERP or HER2. So in suspected breast cancer, we need to confirm the diagnosis. So biopsy is the number one, and ERP or HER2 also can be sent from biopsy. So in this context, right, the best, what they are asking is the best what you can do. What is the question? Best next step, best, the word important is the best. So when they are asking for the best, means you have to answer the best, and best is the biopsy, not the FNSC. If the true cut biopsy is not in option, obviously the next closest answer is the FNSC, right? And when the second, third, and fourth thing will come in the picture, I will open this session for discussions as well. Let me first finish. So once you have done, right, once you have done the biopsy, true cut biopsy, and true cut, this is a classical. I mean, it could be a highest chance that it could be a malignant. 55 years, painless lump, upper outer quadrant, no palpable lymph node, bilateral mammogram shows this bad picture. So until proved otherwise, it is a malignancy. So classical presentation of malignancy CA based is a woman is postmenopausal. Number one. Most important thing is painless lump. So fix in your head. Any female comes to you with a painless breast lump, don't ignore. Oh, there is no pain, no cancer. Let me tell you, by my 20 years of oncology experience, 98% plus tumors comes to me with a painless, no pain, zero pain, painless breast lump. So painless breast lump, especially in a postmenopausal woman, don't ignore it, don't do anything. Just try to evaluate, do mammogram. This is a mammogram. And after doing the mammogram, right, if it is a lesion is suspected, right, and suspected how, there is a one scoring system. This breast imaging, there is a scoring system. Anybody knows what is a scoring system? There is a radiological scoring system for the reading, right? 0, 1, 2, 3, 4, 5 is, anybody knows what it is called, right? It is called BIRAD. So Dr. Rupali answered very correctly, BIRAD. So what is BIRAD? So you can answer, ask me the questions after I finish. So this is excellent classical presentation of breast lump. But what happens? Even doctor doesn't know, painless breast lump, nothing to worry. When there is pain, you come. Pain, breast has never a pain in the lump, right? So and if it is a pain, so it is not like that. So 98% of the I mean female present with painless, right? Even 2% patient also present with the pain, right? So it does not mean that pain is that does not mean. But pain, if it is there in a breast cancer, it is very advanced stage. Let me tell you, it is very advanced stage, right? Pain or inflammatory breast cancer. There is one entity in the breast cancer, inflammatory breast cancer. So in these two condition, right, you can see in a malignant, in non-malignant mastitis or abscess, right, where you get the pain uh, in the breast, right? So this is classically, I mean, suspected case of breast cancer. So we must go for the true cut biopsy. So first step here is doing the true cut biopsy. So first, any patient, any suspected patient, you do the biopsy. After biopsy, you do the staging workup. So breast staging workup we can do with the CT scan or PET scan. So PET scan is the best because it will take the picture from head to toe, right? So PET CT scan here the best. So it is answer when once you diagnose. You are not diagnosed now. So first do the true cut biopsy. That is first step in this case. Once it is confirmed invasive ductal carcinoma or cancer of breast, second most important thing is PET CT scan, right? Bone scan usually not required because bone scan will already come in the PET CT scan, and PET CT scan cover the all the informations of MRI as well. So PET CT scan is the best answer in this case once the diagnosis. So for now, the diagnosis for this based next step in this patient is a true cut biopsy. And if the true cut is not in the answer is a this is BIRAD, as Dr. Amreen and Dr. Rupali said. BIRAD. So what is a BIRAD? So BIRAD is a classification. So BIRAD is a BIRAD. So B breast, I imagine, R reporting, A and D data and system. So this is called RADS. This is international classification given by American Society of Radiology, and it is followed across the globe. So any mammogram comes to you of your patient, they will write down the BIRAD score, right? And BIRAD score will decide it is from 0 to 6, right? So it is 0 to 6. Like CUP score, it is 0 to 5 is a SCOP score. It is a BIRAD is 0 to 6. So lowest is a 0, highest is 6. Let's see how it's 0, how it's 6, right? So you should know now the BIRAD. So BIRAD is not very uncommon name. It is a very common, but you must know being a clinician. So BIRAD is a breast imaging, radiology, reporting and data system. Is a risk assessment and quality assurance tool developed by ACR, means American College of Radiology, that provides wide accepted lexicon and reporting schema on the imaging of the breast. So once you see the breast lump, right? If you see any lump, you you can classify it. Looks like BIRAD 0, 1, 2, 3, 4, 5, 6. Depends on that what's the things, how critical it is, right? And biopsy or not to biopsy. This all decision done on the BIRAD score. So what is BIRAD score? BIRAD 0, right? Mammogram or targeted ultrasound. BIRAD 1 is negative, right? A routine, right? Negative. BIRAD 2 is a benign. It is a job of radiology, so don't get confused. It is not your clinician job, but they will give you in your mammogram report that BIRAD is 3, 4, or 5. Your main job is to interpret it. So 0, 1, 2 is nothing to worry. Rather, up to 3, it is nothing to worry. Probably benign. But 4, 5, and 6. So fix in your head. Any BIRAD with 4, 5, and 6, it is absolutely a critical. You must investigate and you must the biopsy. So BIRAD 4 is suspicious diagnosis by diagnosis by biopsy. Highly suspicious tissue diagnosis again by biopsy, and this is proven case, biopsy proven case, right? So this is 6. If you don't remember, it's okay. So what is the bottom line? Just if you don't remember anything, BIRAD score of 4 and 5 means biopsy. You cannot tell the patient, okay, don't worry, lady, you go home, nothing to worry, your breast painless lump is benign, it is a fibroadenoma, fibrocystic disease. Don't do this loose comment, never ever in your patient. Whenever BIRAD score is 3, 4, 5, get vigilant in your case and try to evaluate by sonomammogram, and if required, do the this biopsy. If you are sitting in peripheral area, 200 kilometers from the city, do FNSC, but do at least something and get the result, get the diagnosis that what happens wrong with the patient's breast lump. So this is how it read. So now just keep in mind. So again, finally talking to our these questions, here the answer is best initial or best next step in the management is the true cut biopsy. Once the true cut biopsy is done, then we may probably go for the staging workup in terms of PET-CT scan and then remaining things. And BIRAD is extremely important. So before biopsy, BIRAD comes. If you do MRI, if you do sono, or if you do mammo, in all three BIRAD will applicable. It applies to the mammo, ultrasound, or sonography and MRI. So whatever the imaging you are doing for your patient, right, this BIRAD will applicable. So just go for the BIRAD and remember 3, 4, 5. This is also little suspicious by my experience of last many years in breast cancer treatment. So beyond 3, I will be very much vigilant. So if somebody noted on the paper that BIRAD 3 by the mammosonogram, means I'm vigilant. I don't want to miss malignancy in this patient. That's it. So this is what the thing is, and there are a lot of literature related with this. I'm not going much in detail. I'll share this PowerPoint with you later on. So here is this. Any questions in the house? Any questions in the house? Any questions in the house? Any questions related with breast cancer? One more minute. I'll give you the opportunity to ask. Don't hesitate, don't shy. If you have any
Sir,
questions, feel free to ask.
sir, sir,
Yes,
can you
please.
clear the true cut biopsy, excisional biopsy, and incisional biopsy? What is the difference?
Yeah,
How
so
two
it's a nice,
different? Yes.
yeah, so it's a nice question. It's a nice question. So let me, so basically true cut biopsy and incisional biopsy, excisional biopsy is, so
Yes.
say for example, this is breast, right?
Yes,
This
sir.
is nipple and this is lump, say for example. So if you are, there is a one gun, you see the YouTube video, there are a lot of videos. So there is a one gun. So what we do in clinical practice, we fix up the lump by fingers, right? We put between thumb
Mhm.
and index finger, we fix the things, enter the gun up to the lump, and there is a fire. Like it's like there is a like a pistol, right? Once you have a, if you click, you get a piece in the that container and you come out. So this is a true cut biopsy, right? So here it can be done in a local anesthesia with 2% xylocaine. You can do it. It's a 5 minute job,
Mm.
right? So this is a true cut biopsy. Incisional biopsy, you make a incision, right? Open incision,
Mm-hmm.
you get a piece of incisional and excision. Completely you remove the lump, or you can say
Okay.
lumpectomy. Lumpectomy. Excisional
Okay.
means completely hold the. So say for example, it is a 2 centimeter lump. So completely you remove complete 2 centimeter of lump. This is excisional biopsy. If you take a one, you put a one incision on the skin and get the biopsy, it is incisional biopsy. And without doing the
Rest.
incision, without excision, you enter one gun into the tumor, you fire the this gun, and you get a piece. It designed in a such a way that you get the piece, right? So these are the
Mm.
various things. But bottom line is that you must know the biopsy, not FNSE, right?
Mm.
If, if biopsy is not available, then you think of FNSE. But if you have a choice, right? So never ever advise a patient to do a FNSE, because there is a chance that you not get the malignant cell, and FNSE is saying it is a normal report, and you are misleading to the patient, and after 2 3 months again the lump is big and you do biopsy and you get the cancer. So here chances of missing is very high, because you are detecting one from 100 or 1000 cell, and you are detecting one from 100,000 cell, right? So the chances is probability is very high with the biopsy, and ERP or HER2 cannot be performed on FNSE, which can be performed. This is high yield questions related with the exam. So I'm just trying to discuss all high yield related things with the exam, right? So this is general understanding. Is that clear, Manjuprit?
Yes, sir. Yes.
Wonderful. So just keep in mind the bottom line is to do the biopsy. Great, wonderful. The next question in front of your screen. HIT means heparin-induced thrombocytopenia. Little change gear from onco to hemato now, right? So I have all varieties. So I have all knowledge will be checked. Gynec, pedia, surgery, medicine, hemat-onc. So heparin-induced thrombocytopenia is a short form, HIT. So which of the following is not true? Not true. This is extremely important. Not true. Not true, right? So don't get confused. So which of the following is not true for heparin-induced thrombocytopenia? Means there are everything is true except one thing which is not true. So they are asking not true. So you decide what is not true, right? Heparin-induced thrombocytopenia type 1 is a non-immune and type 2 is a immune, right? Heparin-induced thrombocytopenia type 1 is non-immune and type 2 is a immune. Heparin-induced thrombocytopenia type 2 can cause thrombosis. Unfractionated heparin, or short form is UFS, unfractionated heparin, can cause low platelet but not LMWH. Observation is a treatment in HIT 1. All of the above statements are true. So it could be all true as well, right? So you need to decide. You need to know little this hematology knowledge.
Mm, Sir, D, I think observation is the no, observation is not only the treatment. We have to check the, INR or something like that.
Okay, wonderful. So let's discuss with you first of all. So which is not true? I mean, what's your answer?
Sir, D, observation is the treatment
Okay,
in
so
type 1.
observation is a treatment is the treatment in type 1. So you think that there is a no observation in the treatment, right? Hello?
My mean is observation is not only the treatment. We have to go for checking INR or something like that.
No, no. So don't, sorry to discuss with you. I'm just trying to understand your concept. So what they are saying, heparin-induced thrombocytia, which of the following is not true? So you are saying observation is the treatment in the heat type 1. So do you think that observation is not the treatment, or observation is the treatment? First of all, tell me that. If you have hit 1, you observe or you treat? Simpler
Sir, we
question.
have to treat it. We have to
Okay,
treat.
wonderful. So I'm trying to discuss more. Okay, so you have to treat it. So how you treat? Now, second question. You feel that you have to treat hit 1, right? Next question, how to treat? How to treat this
By
patient?
low molecular weight heparin.
Low molecular weight heparin. So how the low molecular weight heparin helps in the heat 1? Low molecular weight heparin is for thrombosis, isn't it? Yes or no?
Mm,
Low molecular
Let
weight
me start again.
heparin is for thrombosis, right or wrong?
Yes, yes.
Right. So do you think there is a thrombosis in the heat one?
No.
Sorry.
Sir, I'm confused. But this could not be the answer. The D could not be the
Let
answer.
me. You will clarify next 5 minutes, rather 2 minutes. Anyone in the house? Anyone wants to comment on these questions? Little tricky but important and interesting because this is what I selected today questions is what very important in clinically because heparin is something is used in each and every ICU. No ICU in the world they can say, oh, we cannot use sir heparin. Heparin is a very much absolutely usable things in ICU. And you can see if you are in ICU, neuro ICU, MICU, surgical ICU, whatever ICU, HDU, high critical care unit, you see heparin is used and you get the heparin induced thrombocytopenia for sure in your OPD. If you don't know, you go and ask your intensivist who is in charge of and discuss with him. He will tell, sir, we seen a lot of patients of heparin induced thrombocytopenia. Right. So anyone wants to comment openly? Amreen Fatima, you also posted the answer. All of the above statements are true. So, what's your comment, Dr. Amreen Fatima?
So I'm not sure about this question, but I feel so that all of the above statements are true. So
Fair
I'm
enough.
sorry.
So, have you ever seen heparin induced thrombocyte? Just for knowledge, don't take it other. Have you ever seen the heparin induced thrombocytopenia? Or you heard
Um,
the diagnosis that oh, some of your patient diagnosed by hematologist the heparin induced thrombocytopenia?
yes, I have read it somewhere, but I don't remember it.
Fair enough. So, you go and read it, right?
Yeah, yeah,
I'll
sure,
I'll
sir.
I clarify, but still you read it just to make
Sure.
sure because this is all clinical. BIRAD is extremely important. Community acquired pneumonia, the CUP60 very important. Heparin-induced thrombocytopenia is extremely important, right? So, Dr. Jamal, you just posted the questions answer B. So, can you little bit uh, Sagupt Jamal, Dr. Sagupt Jamal, can you little bit explain me why you selected the B answer? Very important discussion. Yes, Dr. Jamal. Any comment from your side? Fine. No comment. Dr.
Sir,
Bahar?
can I answer?
1 minute, 1 minute. I know you know the answer. 1 minute. Yes, Dr. Bahar Toprak. Yes, now you can answer. I think nobody is ready, so you can answer. So
Sir,
what's your
For the
answer?
answer, I think all statements are true because true. Yeah,
So by you, all of the above statements are true. But by
yeah, I
me,
think all
it's
of
not the
it is
answer.
true.
So it is not the answer. It
uh,
is not the
uh,
answer. It is not the answer. Anyone, open for all. I mean, we are more
C, sir,
than,
option
sorry.
option C. Because the both unfractionated heparin and low molecular heparin both will cause the hit. Not only it's like unfractionated heparin. Hmm.
Excellent. Excellent.
Uh,
Excellent. So
because we
answer
can't
is a
able
C.
yes we can't able to change and anyhow it's a heparin you can't because unfractured heparin will cause less than hit less than low molecular heparin but still it is going to cause it.
Excellent. Excellent. So answer here is C. Let me go to the literature. I will go to you. Heparin induced thrombocytopenia type 1, heparin induced thrombocytopenia type 2. Right? What is the difference? What is the major difference I'm telling you? So heparin induced thrombocytopenia type 1 is non-immune. So there is no antigen antibody related reaction, no antibody form production. You give the heparin, platelet will down. There is no antibody production. This is immune mediated. This is number one difference. Major difference I'm sharing you. This will develop heparin in once you give the heparin within within 12 hours or 1 day, right? Develop. So in 1 to 3 days, develop, right? So 15th you had patient admitted in ICU, it can develop on 16, 17 or 18 means immediately within 24 hours it develop. And here the time frame is usually after 4 to 5 days, the platelet will reduce. So here on admission platelet is 200,000 and next day it is 150,000, means it is type 1 within 24 hours. Here the same patient 200,000 on admission, after 6 days 150. It took 6 days to develop, means some kind of antibody develop which kills the platelet. So it is a immune mediated. So it's a slow, low, later in the process. So these are the very high yield point. One difference is non-immune. Second is a time frame. At what time administration of the heparin and what time frame you get the reduction. Third thing, how much platelet will low. So here it is not very critical. It's non-immune. So usually platelets are reduced, but it is at least more than 100,000. And here it can go up to less than 15,000. So severity of the thrombocytopenia is very, very high and low and deep, right? Where here the mild thrombocytopenia, it could be a severe thrombocytopenia. Fourth thing, here just for your knowledge, right? Unfractionated heparin as well as low molecular weight heparin can cause one. Here the unfractionated heparin and low molecular weight heparin can cause the thrombocytopenia. The question is that unfractionated can cause, low molecular cannot cause thrombocytopenia. That is a wrong. Both the forms, any form, heparin induced thrombocytopenia, heparin induced. So heparin, there are two forms, low molecular weight heparin and unfractionated heparin. They are not saying that LMWH HIT. They are not saying UFH HIT. It is a heparin induced. So wherever the heparin word comes, means it causes the thrombocytopenia. Statistically, 5 to 10% of the unfractionated heparin, here they are 2%. Percentage are less with low molecular weight heparin. So if you have choice what to use, low molecular or unfractionated, better use low molecular. Why? The side effect or thrombocytopenia incidence and prevalence is less than unfractionated, but both can cause, for your clarity, right? Fifth point, no thrombosis. Here, no thrombosis. No thrombosis. And that is why somebody given me the answer, give the low molecular weight heparin as a treatment. So don't give the treatment, no thrombosis. Patient is usually asymptomatic, usually no bleeding. And here the treatment is observation, and stop the heparin. That's it. So biggest treatment is a stop heparin, either LMWH or unfractionated heparin. You stop and observe the patient. Once you stop, it will come up in 2, 3, 4 days. That's it. Until and unless they are bleeding very badly, you don't treat. Just observe. Fifth and sixth point for this, no thrombosis here, very bad thrombosis, very bad thrombosis. In my 20 years of clinical practice, I have seen and treated two patients only so far. One patient from UK developed the heparin-induced thrombocytopenia type 2. He developed the thrombosis in the heart on the left atrium. I remember still the echo. There is a big thrombus in the heart. Also, this patient has a deep vein thrombosis. And here the treatment is anticoagulant, but no heparin, because it is because of heparin it developed this. So no heparin. So you give the direct thrombin inhibitor. The name of the drug is direct thrombin inhibitor, right? You need to give. I will give on the next slide the drug which acts on the heparin induced type 2. But the name of this drug is direct thrombin inhibitor. So there is a clot. So you act directly on clot, that is called direct thrombin. Thrombin means thrombus. Thrombus means clot. So it acts directly on the clot. So direct thrombin inhibitor is the drug of choice. If they ask you in the exam, what is the drug of choice for heparin induced type 2? And drug of choice is the direct thrombin inhibitor. That's it. So, and here the thrombosis is so bad that patient may die. Fortunately, both of our patients survived because we picked up early on the time of thrombosis. We did all workup for thrombosis, detected heparin-induced thrombocytopenia. We give the thrombin at that time, 15 years back. One patient, I remember, we brought it, the injection from UK, same patient from UK. So we procure, but it survived fortunately. So doing well, and platelet went up to more than 150,000. So this is a beauty of these things, right? So again, very excellent slide. One slide, you can take a picture. I will share with you as well, right? So heparin induced thrombocytopenia nutshell, and this is type 2. Head-to-head comparison, non-immune. I already told you this is immune. I told you the percentage incidence is high with unfractionated heparin. UFH is unfractionated heparin, 10 to 30%, here 1 to 5%. It is not zero. If it is zero, then it is a wrong statement, right? So it is not a zero. Even low molecular weight heparin can cause. Less common with LMWH, but it happens. time frame I told you 1 to 4 days after starting the things, and this is 4 to 16 days, so little late. Here the platelet counts is usually more than 100,000, here less than 50,000 can occur in my patient as well. Here no antibody, that is why it is a non-immune means no antibody, immune means antibody. So antibodies, yes, thrombosis is never happened, no. Here yes, here management is observed. So somebody answered observation is not a treatment. Let me tell you, observation is the treatment. So it is not wrong answer, it is correct answer. So you can observe in heparin-induced thrombocytopenia, especially patient is asymptomatic or non-bleeding, right? And it is a self-limited. So you just stop the heparin and observation. We'll solve the problem here. Here discontinue heparin obviously because it is heparin-induced. Whatever LMWH or UFH, start DTH, direct thrombin inhibitor, direct thrombin inhibitor, direct thrombin inhibitor. You must use, otherwise patient will die. Death is happen not because of thrombocytopenia, because it is heparin-induced thrombocytopenia, means low platelet count, thrombocytopenia, but they die because of thrombosis. So very bad thrombosis in the heart or in the lung or in the brain, they may die. So one of our patients survived, one is we could not able to survive or revive. So that's the story. This is the things. Let's get back to the questions and try to reanalyze the questions. Which is right or wrong, true or wrong? Heparin induced type 1 is a non-immune and type is immune. Is it true or wrong? True or false?
It's
Tell me at
true.
least you are awake. True.
True,
Heparin
true,
induced type 2 can cause thrombosis.
yes,
True or false? True.
True.
true,
Immune mediated, that is why thrombosis. Observation is the treatment in type. True or false?
true.
True.
It's correct.
True.
Unfractionated heparin can cause low platelet, but not LMWH. False.
Both can cause.
Both can cause. So answer is C. Not true. So this is not true. LMWH also can cause this. Open for discussion. I tried my level best to explain you things properly. I do my best. Still, if you have any confusion, it's open. Anyone, any questions, Preeti? Dr. Bahar Toprak, any questions? Dr. Dania, any question?
Last option is quite confusing, isn't it? So all of the above statements are true means, of course, the C option is not true.
Yeah, it's not true.
When
And that is what the question is, no? Which of the following is not true? So not true is a C. C is not a true. Why not true? Because low molecular and unfractionated both can cause. What they are saying, not LMWH cannot cause low heparin-induced thrombocytopenia. So it's a wrong statement. It also can do. Is that clear? Yes or no? Yes or no?
Okay.
Any confusion? Dr. Kanwal Noor, any confusion? Fine. So no confusion, no questions means I take it granted that you understood all well and you will probably answer well in your exam. So I would be glad. And this is what the, again, story, same thing. So you read it later on, but this is what the thing is. I already explained you. And direct thrombin inhibitor are these are the few name, all right? Ergotaban, ergotaban, bivilirudin and lapirudin. So we used in our patient, my patient, both the patient, we use the lapirudin. So lapirudin is a direct thrombin inhibitor. So you must use this. You cannot use heparin, right? Anticoagulant, because of heparin this problem happens. So you cannot use heparin in any form, unfractionated or low molecule. That's it. If you do not have questions, I'll switch to the next question. More 5 seconds I'll give you. Any questions? All clear. Wonderful, Manjit. Check your ECG now. Switch your gate from hematology to cardiology. Various questions, different. We see pneumonia means respiratory. Then we see a curve 65 is a respiratory problem. Then we see after that we see BIRAD. After see
my
breast
God,
cancer. Before that we see this respiratory we have seen. Cardiology we are seeing now. Oncology we see. Hematology we see. Now hematology heparin and now come to ECG part, all various different questions. So your check knowledge. This is how exam they ask. They won't ask you 100 questions of gynec or hemat. They ask all department. So you must know all department. The patient is placed on the cardiac monitor. you immediately right, and you see this rhythm, right? You see this rhythm, you immediately recognize this rhythm, and you need to diagnose that what this rhythm is. If you ask the patient history, I can tell you 50 years male, presented with some lightheadedness, right? Little heaviness in the chest. Vitals are stable, pulse tachycardia, respiratory rate is normal, lung examination is normal, no heart sound additional, no murmur, nothing, just heart tachycardia. Otherwise, cardiovascular S1, S2, S3, S4 is usually not seen, but S1, S2 is normal, right? Otherwise, fine. Lung examination is clear, no bronchi, no craps, no foreign sound, no reduced air entry, right? No hyper resonant, no dull. Normal heart, normal lung examination, all except tachycardia. You find this ECG. Now comment on this. Is it SVT, that is supraventricular tachycardia? It is VT, it is ventricular tachycardia, VF or ventricular fibrillation, atrial fibrillation. Yes, Dr. Bahar Toprak. Your answer is B. B means ventricular tachycardia.
Yeah, because it's narrow and regular rhythm. I think it's just ventricular tachycardia.
Okay, so how you differentiate between VT and SVT? Say, for example, what is the differentiating point between VT and SVT? So
So
your
the
answer is VT. First
time
answer is
interval,
SVT. Okay, let first Bahar Toprak to finish it off, then we'll discuss with another. Yes. Because we need to know, na? We don't need to mug up the ECG that, okay, this ECG will come SVT. Okay, fine. I'm happy. But at least you need to give some answer. You need to differentiate. Na? Probably this ECG will not come in the picture. Another ECG they will. Yes, Bahar. Any comment or Bahar Toprak? So if I can say this is not a ventricular tachycardia, that's not the answer. Then what's the next? Yes, Dr. Neha. Ashba Neha. Any comment on this?
It's a
Yeah, discuss.
SPT, it's a supraventricular tachycardia because narrow complex and tachycardic and no definitive P wave.
Okay, so what point favoring for simple direct questions, right? So say for example, if you don't mind,
so
you
it's
can
a
discuss.
rate. It's a rate
One
of the.
second,
It's
fine. I'll come to you, Dania. So sinus tachycardia and supraventricular tachycardia. Yes, doctor. Yes, Dania. If you want to answer, answer this. How you differ sinus tachycardia and supraventricular tachycardia? What is the difference?
Sinus tachycardia will be there. PQRS wave will be there. And SVT don't have P waves because it is
So
happening above the ventricles. So we will miss the P waves. Where the ventricles are working properly, so QRST will be available.
you need to know three, four common basic thing for any ECG. How is the pattern in sinus tachycardia? How is pattern in supraventricular tachycardia? What is the rate of sinus tachycardia and what is the rate of supraventricular? And how PQRS and T looks like in sinus tachycardia and how it looks like in a supraventricular tachycardia. And last and not least, what is the treatment of sinus tachycardia and what is the treatment of supra? So if you know this, you will 100% answer any question in exam for ST and SVT. This is how it should be your preparation, not the mug up, ratto fine. No, it won't help you. Yes, Dania, tell me now. Dania, come up now. Any volunteer. We are more than 30 people on Sunday. 30 in the class at least. Any one volunteer who can answer properly or who is confident? Anyone, including Preeti.
So can I try?
Yeah, 100%.
Yes,
100.
doctor.
This is the
Sir, I
learning
think,
platform. You try everything you try. I am not
yes,
at all
sir.
in
As
hurry.
I said, the pattern will be for sorry, sinus tachycardia, there will be PQRST,
So this is the P
where
Q
PQRST,
R S T, right?
T, but
Kind
the
of things,
rate,
right?
yes, but the rate will be like till 150, up to 150.
Okay, so
It can
usually
be,
it is not 150, more than 150.
okay,
Usually
sir.
not more than 150. Okay, what
Not more
else?
than 150, yes.
So here
And
what? Here pattern is PQRST. Here what pattern?
we can get QRST where the P will be missing because they don't have time to for the atrial depolarization. So we will
Fine.
be missing the
So,
P wave.
so just for your knowledge and quick things, the biggest point here, SVT, whenever you answer SVT in your exam, remember only one point. P and T cannot be differentiate, or you can say they are overlap, right?
Yes, sir, overlap, correct.
We'll see in this ECG only. So remember this point. So whenever you answer SVT, look at only one thing. Can you able to identify where anybody can identify where is P wave and where is T wave?
No,
Anyone
sir.
wants to try on the ECG, you try.
No.
Where is the P wave? Tell me, and where is the T wave? You tell me. Can you able to identify yes or no? At least tell me yes or no.
No, sir.
Sir, no.
No means P and T cannot be identifiable. It cannot be separated. It can be overlapped. That is SVT number one. Here the rate tachycardia. So first of all, before tachycardia, we need to know what is pulse rate, right? So 60 to 90 is a normal. Anything more than 90 to usually 150 is a sinus tachycardia. 150 to 250 could be supraventricular tachycardia. Anything more than 250 could be ventricular tachycardia. Just general understanding. There is no rocket science. This is clinical observations of me and book. In the book, if you go by just pulse rate, this is what it is written in general, right? So this is the
Excuse
thing.
me, is it 90 or up to 100? It's normal.
I guess 90 in some books say 100, depends on age. Again, that is a factor. So at least I'll put it 100. You are more expert, sir. Okay, so 60 to 100, some books say 90 anyway. It's like blood pressure. So if you see Oxford Handbook of Medicines, little different range of normal. If you see Davidson, it is little different. And if you see Harrison, little different. If you want to try, go and read Harry, normal blood pressure range in all three books. Little change, but in general understanding. Anyway, so pattern here the more than 150, and here P QRS and T, you can absolutely completely identify. Here you cannot identify P and T because they are overlap, right? So here you can see P. If I say P, then where is T, right? Where is T? If I can say this is T, then where is P? So you cannot identify, right? So this is morely you can see the tachycardia. How you differentiate tachycardia? This two block. How you calculate two block? How you calculate between two RR, between two RR, right? So between two RR, 300 between distance between two RR2. So here the pulse rate is roughly 150. Yes or no? Are you agreed or no? Yes or no?
Yes.
Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
For your comment. So at least
Yes, sir.
involved.
Yes, sir.
Get involved in the talk. Wonderful. So this is what the thing is. Now see, this is excellent picture. I put it for your clarity. Here I can mention all the waves name. This is P, this is Q, this is R, this is S, this is T, again P, here Q, R, S, and T, again P. So can you see? I can identify complete PQRST complex, which is not possible here. You identify here and tell me. You cannot. Is that clear? Yes or no? At least say
Yes,
yes or no.
sweetly.
Right? So here you cannot identify. Here the sinus tachycardia 1, 2, 3. Here 300 divided by 3 means pulse rate is roughly 100. Here 2. 300 divided by 2, so pulse rate is 150 at least. Right? So this is the biggest difference between sinus tachycardia and what is the treatment. Treat underlying cause. This is very simple. Underlying cause you treat. Here you also treat underlying cause, but here you want to do something to reduce. Here you don't need to do something to reduce the pulse rate. Say for example 105 pulse tachycardia, right? And you have 104 fever. So So what you need to do? You control the fever, it will come to 80. If you have dehydration and sinus tachycardia, give the IV fluid in acute gastroenteritis, treat it. That's it. So this is how it's treated, underlying cause. Right? Say for example, septicemia. Patient has a fever, patient has a septicemia, patient has a high grade fever, and patient has a pulse rate of 110. So treat the septicemia, it will treat the fever, it will come down the pulse rate. Right? So here you need to treat the underlying, here you need to treat underlying, plus you need to treat this patient because in a refractory case they may die. End point of SVT is they may die. They may die. So can you tell me, Priya or Yoga Priya, what is the treatment of supraventricular tachycardia? Yes, Dr. Inga, do you have any comment? I think you posted that it looks like atrial flutter.
Yes, it's okay. I'm in my general specialization. I'm cardiologist. That's why it looks like blockage in atrial flutter. Heart rate here is the question. About the treatment, if it's paroxysmal supraventricular tachycardia, it's vagal maneuver. First treatment is vagal maneuver.
Okay, vagal maneuver you first do. So how the vagal maneuver is going to help this patient? What exactly the vagal maneuver will does, and what and how it reduces the pulse rate? Just for knowledge.
It's not reducing pulse rate. It's changing the supraventricular paroxysmal tachycardia to the sinus rhythm. Supraventricular tachycardia is not sinus rhythm.
Fine. So what exactly the vagal maneuver will do?
massage? You mean
Yeah, so
vasovagal massage?
Yes.
Okay, patient is sitting, blowing in a syringe for 15 seconds. Then he is lying down with his leg up 40 degrees, 30 seconds, and sitting again. It's like a new vagal maneuver position. All this structure is changing non-sinus rhythm with paroxysmal tachycardia in sinus rhythm. In probably with a healthy adult around 80%, if it's a new paroxysmal tachycardia, if it's a new case.
Great, wonderful.
Or second
So
is adenosine IV, but only with monitoring.
Yes, that's correct. So
With cardio
basically,
monitoring.
as she is rightly told, the conclusion of the talk is you do the vagal maneuver. There are various ways to do the vagal maneuver. One of them is a carotid massage. Another is a Valsalva maneuver. So those who don't know how to do the vagal maneuver, it's a life-saving, it's a important, and SVT is not an uncommon problem. You get a lot of patients in elderly patient. You see a supraventricular tachycardia. So go and read it today, supraventricular, three, four things, right? As I told you in my every lecture, right? Supraventricular tachycardia. First of all, how you diagnose supraventricular tachycardia, how you investigate supraventricular tachycardia, and what are the treatment modalities. Very frequently, questions asked in the exam, SVT. So as we detected this is a supraventricular tachycardia, let's jump to the treatment of the supraventricular tachycardia. So what is the biggest difference as I told you, right? So it is very well mentioned, sinus tachycardia, that is ST, and supraventricular tachycardia. So tachycardia develops above the ventricle, supraventricular. So this is the heart, right? There are four chambers. So this is the ventricle, right? This is left ventricle, this is right ventricle. So so develop above the ventricle. That is why it is called supraventricular tachycardia. If it is developed from ventricle, it is called ventricular tachycardia. Simple. So this is supraventricular, right? So some accessories, pathways, generation, ischemia, right? Some drug can cause this, right? So it is not a ventricular, it's a supraventricular. So supraventricular tachycardia number one is a more symptomatic than sinus tachycardia. Sinus is, as we discussed, 100 to 150, here 150 plus 2, usually 250. With sinus tachycardia, P, Q, R, S, and T is very well defined. While in sinus tech, P wave and T wave are separate, while SVT they are together, they are overlap. You cannot identify. This is the general thing. Summary is what for the treatment? SVT, first of all, use the carotid massage, that is also called as a vagal maneuver, because you stimulate the vagal now. It's a parasympathetic now. So go in little bit read, right? So what you need to read is a vagal maneuver, right? So go and read it. Uh, if after doing the carotid massage, do it on one side, not on the both side. Let me tell you. So don't do it on both the side. There is a carotid bulb in the neck in front of the carotid
Excuse me, sir.
artery, right? One second, let me finish. So carotid massage, and if you do, and there is a no reduction of pulse rate or there is no response, then adenosine is the first drug of choice. That is again a question in exam. Long scenario, carotid massage doesn't work. What's next? Adenosine. This is dose 6 milligram. First you give the dose. If doesn't respond, give 12 milligram. If no response, again give 12 milligram. So just shortly I read 6, 12, 12. Oman Viva, they asked a lot of questions about this. That is why I put the dose as well. If no response of this adenosine, so carotid is failed, adenosine doesn't work, use the verapamil. 5 means 5 milligram, 5 milligram. If no response, etinolol. All lol is a beta blocker. Etinolol, esmolol, metoprolol, bisoprolol. Lol is beta blocker. So lastly, beta blocker 2.5, 2.5, 2.5. So maximum 10 milligram beta blockers give. If no response, do the cardioversion. That's it. So this is what the management is. You need to know simpler in a simpler language that okay, one fails, what next? One fails, what next? Right. So this is what the thing is. And complications over a time, untreated and frequent episode of SVT may weaken the heart and lead to heart failure, particularly if you have other coexisting medical condition like chronic asthma, hypertension, diabetes, or smoker where heart lung is not good. There are more chances of getting complications and refractoriness as well. And in extreme case, an episode of SVT may cause unconsciousness or cardiac arrest. So this is bad part. Unconsciousness or bad because heart is pumping so fast, it's not coordinating, ventricle is not generating the, I mean, pumping the blood to the vessels or systemic circulation. Initially, they have unconscious because of reduced cerebral blood flow, because of cardiac arrhythmia, and cardiac arrest may happen very rarely, but it could be there. Now, somebody was asking question.
Treatment is
Yes, please.
depend on the patient is hemodynamically stable or not. No, then it's
Yeah, it is.
if it is hemodynamically unstable, we have to directly go for the cardioversion rather than trying things
Exactly,
outside of
exactly.
medication.
You are absolutely right. So if patient comes with a pulseless with this ECG, it's unstable, right? So you need to directly go for cardioversion, right? But depends. But this is general protocol for your knowledge and understanding, right? So that's it. So now the homework. Now the homework is what? I taught you the supraventricular tachycardia, but this ECG you must know. First of all, you must know normal ECG. You write down in your notes. This is homework. So first of all, you need to know normal ECG. Once you know the normal ECG, less critical is sinus tachycardia, then supraventricular tachycardia, then ventricular tachycardia, ventricular fibrillation, first, second, and third degree heart block. That's it. This ECG minimum, and obviously ST elevation, STEMI, you cannot miss STEMI. So these are the basic. You don't need to know whole Parkinsonism, White syndrome, and blah blah, and very very critical ECG. They want us. Usually they want us, but you should know this basic 5 6 ECG. You must know how you identify. How you differentiate. So first normal, then ST, sinus tachycardia, supraventricular, ventricular fibrillation, right? And obviously same ventricular flutter fibrillation, atrial flutter fibrillation, AF. That's it. So these are few 6 7 ECG you must know. So if you don't know, it's there on our website in our CPR section or cardio section. We have all ECG. We have all properly mentioned ECG with answers explanation. So you go and little bit read it. Right? It is absolutely there. You don't need to struggle to get ECG. Everything is there on our medical MCQ for all website in cardio and CPR. It's already there. So that's all for this one ECG to check your knowledge about ECGs. So there are few ECGs, but you can practice it and get back to me. Next question in front of your screen. A 17-year-old girl is brought to the clinic by her concerned mother because she has never had a menstrual period. 17 years of age, no menstrual period. The mother reports that her daughter has good grades and studied hard, but seems stressed most of the time, which is why she believes no period, because she is all the time studying, probably in stress, and mother thinking there is no period because of stress. On examination, girl seems to be well nourished, adult breast development and pubic hair present. Pelvic examination reveal a foreshortened vagina. No uterus is seen on ultrasound. And what is the most next appropriate step? So this is the clinical context of the patient with you. Now they are asking, when you don't understand any MCQ, this is a out of the way my tip. When you don't understand any questions or it is a very long question, 20 lines question, at least the last one or two line, you will get the idea. This is just general experience sharing. So if you forget all 20 lines further and 21 and 20, there are 22 line questions, right? So 20 lines you forget while you are coming 21. So look at the 21, 22 means last two lines. There is some clue in this last two lines. This is my just general observation. Because sometimes we scared of long scenario and while we come from here up to down, we forget earlier story, what happens earlier. Again, we are reading, wasting the time in exam and it's limited. So if you don't understand anything, last two lines is very important. So they are asking what is the most appropriate next step? CT scan of brain to evaluate pituitary tumor, estrogen progesterone supplementation you give for some development, considered in vitro fertilization for future fertility, right? Because the uterus is not seen, so she will not conceive, obviously, and surgical removal of the intra-abdominal testis or vaginal dilator. So here, first of all, anyone if answer to me, right? First of all, you need to make a diagnosis, our routine triad, right? So our triad is diagnosis first and treatment as well. So we need to do both the things. We need to, yes, Dania. Dania, what's your diagnosis? Why you want to do the CT scan of pituitary for this patient? What is the differential diagnosis? Dania. Because you posted the answer, so there must be something going in your brain, right? This could be a diagnosis. Yes, Rabia M. What's your diagnosis? First diagnosis, then treatment.
Sir, I answered like after ruling out the other options. I don't know if I'm correct or not. I think it could be either Mullerian agenesis or complete androgen insensitivity.
Okay, great. So I'm
Because
at least happy. At least you come to some reach to diagnosis. Mullerian
because
agenesis, that is one thing, and another is androgen insensitivity syndrome. Fine.
okay. Because here the patient is having adult breast development and the secondary sexual characters are normal, like pubic hair is present. But in ultrasound, there is no uterus. And there is foreshortened to vagina.
Okay.
So,
Sir, but there's
so
no
I
uterus
think
seen on ultrasound.
the best option is we have to do a karyotyping or testosterone testing.
Yeah. So what you want to do now?
Here, I thought if it is in complete androgen insensitivity, the patient will be having high testosterone, and the patient will have testes also.
Okay.
So I think, I don't know, sir, if I'm correct.
It's fine, no problem. So what's your homework today is to read differentiating point between Mullerian agenesis and androgen insensitivity syndrome. 100% question will come, right? So I don't want
Yes,
to lose
sir.
your marks in the exam. That is why I selected little tricky questions as well. So it will brainstorm your things, right? Easy question,
Yes,
you will not brainstorm. This is absolutely all questions are brainstorm. Dr. Kanwal Noor, would you like to comment, doctor, anything on this question? You're going great. Your answer is correct. Any comment?
So CT scan is for the any of pituitary tumor because it may suppress the secretions of hormones.
So what is the diagnosis? First of all, tell me the diagnosis. Is there any intracranial tumor, pituitary tumor, brain
Mullerian
tumor?
agenesis will be the diagnosis, sir.
Yeah. No, let the
But they
Dania to
don't ask
answer
the
now.
diagnosis. But they didn't ask the diagnosis. They asked for appropriate next step that for which screening test and for what you have to do.
Yeah, so no problem. So your answer is a CT scan of brain to evaluate pituitary tumor, right?
Yes,
Rania?
sir.
Okay,
Or
fine. So let
maybe
me ask you one
not
more
A then
question.
D. Yes.
No, no. Let me ask you one more question. So if you do the CT scan, sorry, CT scan of brain or CT brain you did, hidden this CT brain you did, pituitary, what you are looking abnormality in pituitary in this case? Are you thinking some pituitary tumor? Are you thinking something wrong in the pituitary? Are you thinking something wrong in the pituitary or peripituitary
Because
areas?
the hormones they are secreted from there. So maybe it may suppresses the insulin
Okay,
hormones
so
production.
is it possible because of that hormone, uterus is absent in the
No.
tummy?
Yes, that's the point I was missed. That's why I posted the answer before.
So if
So
hormones
this
are
is my
up
wrong
or
thing.
down, do
Yes.
you think there is a no uterus in hormone up and down?
No. That's a defect by
Right.
birth
So
defect.
see, so A is gone basically. Am I right? Yes or no?
What, sir? Sorry, I didn't hear
A
you.
option is gone. A option is gone, right?
Yeah, but they
A
didn't
option.
say that they have any testes. They saw any testes. So why the surgical removal of
I'm
intra-abdominal
not saying
testes?
D is also not answer. Let me tell you, D is also not the answer. I'm just trying to understand your answer because you posted the answer A. So I'm just trying to understand what's in your mind that it makes you to think of answer A. That is what I'm trying to discuss with you, just to make you more clarify your thought. Right? Hormones are, yeah. So I think Dr. Kanwal is posting the correct answer perfectly. Anyway, so answer here is a Mullerian agenesis. Right? So first of all, understand what is Mullerian agenesis. Simple, not complicated. So Mullerian agenesis is, this is all picture I got it. So this is normal uterus. So here you can see this is a uterus, right? Then here the cervical part, vaginal part, fallopian tubes, ovaries, blah blah. So this is absolutely all normal. Here what they have shown in the red is not developed. So fallopian tube is not there. Complete uterus, cervix, and upper part of vagina is not there, right? It is not there. So what is there in the Mullerian agent? Ovaries are there. Ovaries are there means hormones are normal. Hormones are normals means hair is there, right? So this only things are not there, and that is why the uterus is absent. Uterus is absent on the USG, or there is no uterus, right? So this is a classical case of Mullerian agenesis. This patient has a Mullerian agenesis resulting in absence of not just uterus. Below uterus there is a cervix, and below cervix there is a upper vagina. So all missing. So uterus completely, cervix and upper vagina. Ovaries are intact, and estrogen levels are normal given the patient's normal secondary sex character. If the secondary sex character were not there, means breast development, pubic hair, if it is not there, it's a hormonal issue, but it is not there. Why? Because ovaries are intact. You can see the picture, na? That is why I took this picture, just to have little more clarity to somebody who does not have idea about Mullerian agenesis, right? So this is a Mullerian agenesis where uterus, cervix, upper part of vagina is gone. And the best thing is the vaginal dilators are an effective first line treatment to allow the satisfactory sexual intercourse. She has some anatomical defect. This is not there, right? Vagina may be constricted, right? So for this, the answer is this, right? So what is the answer? Vaginal dilators. What is the best next step? Not A, because we are not thinking any brain tumor, we are not thinking something wrong. Estrogen progesterone supplementation is not required because the secondary sex character are normal. So indirectly it suggests that hormones are normal. So when hormones are normal, no need to supplement. Consider in vitro for future fertility, that can be done, right? Surgical removal is not required now. So the most important now is vaginal dilator, and in future you can think of that things. That's it. So just move to the next couple of last questions, then we have some feedback. Very simple, one liner question. Identify the grade of diabetic retinopathy. Identify. This is a picture in front of you, right? I should not give the clue, but still in the round arrow it is given as AV nipping, means atriovenous nipping. Grade 1, grade 2, grade 3, grade 4. The most simplest, easiest question of the day. Probably difficult as well. Identify the grade of diabetic retinopathy. Grade 1, 2, 3, 4. I want Everyone post the answer. We are 30 people still in the class and only one or two answer. No one, or else I'll tell the name. Dr. Hina, Dr. Rupali, Dr. Bikramjit Singh, anyone, Dr. Sanina Mansoor. Yeah, post answer, it's fine. Dr. Ishaq, you post the answer. Consider, sir, in that way. If the same questions will come in your exam, what will you post? You need to put something. No? You can't make it blank. You cannot make it blank. Yes, Dr. Neha.
So this is a atriovenous nipping or nicking. I heard about nicking,
Nipping.
but not
Nipping. Nipping.
I heard about nicking.
Consider that both are same thing, nicking and nipping. Now, what's the answer? Fine. So most of the people had a correct answer, definitely, but very few people posted the answer. Right. So this is the staging. Right. This is excellent picture. I got it today for you to teach. Right. So diabetic retinopathy classification basic is in two way: non-proliferative. DR means diabetic retinopathy, and proliferative diabetic retinopathy. So there are two major. Non-proliferative means there is a no neovascularization, no new blood vessel form, no neovascularization means non-proliferative. They are not proliferating, and one is a proliferative. Out of this this is bad, prognostically bad. This is good. I mean, any diabetic retinopathy is not good comparatively. So if you're non-proliferative and if you're proliferative retinopathy, non-proliferative is better than proliferative. If you don't do anything at this stage, non-proliferative, they may convert into proliferative, complete blindness, that retinal detachment. That's it. So just this is basic things. There are four grades: grade 1, grade 2, grade 1 is this arteriolar thickening. So this arteries become little thick, arterial thickening. Tortuosity, this is grade 1, right? And there is a silver wiring. So sometimes what? Silver wiring, silver wiring. This is all you can see with the retinoscope, not in the naked eye. Grade 2 is our answer. AV nipping. AV means arteriovenous nipping. So arteriovenous nipping means what? Artery is going, venous is crossing, nipping, crossing, right? So here you can see arteriovenous nipping. So its answer is grade 2. Our answer is grade 2. What is grade 3? Grade 3 is a retinal ischemia, very or more advanced stage, flame shaped or blot hemorrhage or cotton wool. So they will in exam will they will put cotton wool. And fourth is papilledema. 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 So why the retinal when you give any reference to this, right? Any ophthalmologist, they must find and see the retina and say there is a papal edema is there or not. If it is there, it is grade 4 advanced. And what is a contraindicated in papal edema? If you have papal edema, which test you cannot do? Question in exam. No option, no clue. If you have papal edema, one test you cannot do or perform. What is the name of that test? Anyone? Anyone? Related with the CNS test? No one? Surprising.
LP, sir, LP.
Excellent. LP means lumbar puncture. Lumbar puncture you cannot do because when you do the lumbar puncture, this edema may increase by increasing the pressure in the spinal canal, and there may be a rupture or detachment of retina or rupture, and that is why you cannot perform. So before doing the LP or lumbar puncture, we should do the retina
Retinoscopy.
examination and edema, papilledema. We must look for the papilledema. Right? Excellent answer. Excellent. Wonderful. And can anyone tell me what is the treatment of non-proliferative and proliferative retinopathy? That is the next question in the exam. So what is a non-proliferative treatment? Non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. What's the treatment? So if you don't know, this is the treatment. All right. So what is the treatment of non-proliferative? This is ask question, exam question. So I'm trying to cover a lot of question in one question. So treatment of non-proliferative diabetic retinopathy
So,
is based on severity. Assuming there is no diabetic macular edema, most patient of mild NPR, non-proliferative, can be observed. So you just observe. And non-proliferative diabetic retinopathy, biggest treatment is to control diabetes. That's it. More advanced cases, moderate to severe, non-proliferative, can be treated with intravitreal injection or laser photocoagulation. So this is your answer. Intravitreal injection or laser photocoagulation, non-proliferative. What's the treatment of proliferative? Laser treatment usually works very well to prevent the vision loss. If it is done before the retina has been severely damaged, it may also help with macular edema. Severe proliferative retinopathy treated more aggressively, laser therapy called scatter or pan retinal or photocoagulation, pan photocoagulation. Remember this word. Here the laser photocoagulation, pan retinal photocoagulation to prevent the
um,
neovascularization. Right. So this is what the treatment is. So you go and read. Go
PRP.
and read the diabetic retinopathy, your homework. Diabetic retinopathy. Every one
Sir,
out of
I knew about
one.
PRP because my father got this
Great, wonderful. So PRP
PRP.
is platelet rich plasma, if I'm not wrong.
No, no, no. It's a pan-retinal photocoagulation. He got that.
Sorry, wonderful.
Sir,
So pan
can I ask
retinal.
you one doubt, sir?
Yes, please. Yes, please.
Sir, from this grade, which is non-proliferative, up to what grade we can say it is non-proliferative, sir?
Up to three, doctor. Usually up to three. They usually don't get proliferated, right? First
Okay.
simple edema, then non-proliferative, and eventually advanced stage 4. They are proliferative, means proliferative simply, if I can say, there is a new blood vessel formation is there. And when there is a new blood vessel formation is there, there are more complications, right? Risk of increase the risk of rupture because it's malformed arterial and venous, right? And there is a risk of retinal hemorrhage is also there. So you need to do something before the hemorrhage happens, right? Little simple last couple of questions. Newborn present with heart failure on examination, there is a bruit over the USG shows hypoic mass with moving shadow, likely diagnosis. Newborn present with heart failure on examination. There is a bruit over area USG shows hypoechoic mass with moving shadow, likely diagnosis. Medulloblastoma, vein of Galen, arachnoid cyst, or encephalocele. Yes, Amreen, any comment? Right, so everybody rightly said it is the veins of Galen. So what is the veins of Galen? So let me tell you, rather than mugging up, this is normal. So what is normal? This is artery, right? Then there is a capillary where the artery and vein gets club up. It is called small vessel. It's capillary where the this all oxygen dissociations and transport happens at capillary level. So artery, capillary, and then vein, right? And this is oxygen molecule you can see, which is like transported through capillary. But unfortunately, in veins of Galen malformation, there is no capillary. Red is artery, blue is a vein. So right, and in between capillaries. So capillary is absolutely gone, right? So here the vein, blue is vein, red is artery. So artery and vein, so capillary congenital malformation. So what is the veins of Galen? A veins of Galen malformation is type of cerebral atriovascular malformation, a rare blood vessel abnormality inside the brain. In VOGM, that is a veins of Galen malformation, mishappen arteries in the brain connect directly with the veins. So artery directly connect with the veins. There is no capillaries in between. Instead of connecting with capillaries, which helps slow blood flow. This causes a rush of high pressure blood into the veins. The high pressure blood flows frequently lead to congestive heart failure or hydrocephalus. And our patient is already in first line, newborn baby with heart failure, and now this is the hydrocephalus. However, every VOGM is different. The severity of the condition and the severity of its correlation symptoms differ from child to child. Most children experience some stress on the heart or hydrocephalus before or shortly after birth. The most children have at least subtle symptoms, but the time they reach 1 month old. This is the homework for you. So I specifically write down how you gonna treat these patients or malformation of Galen. This is your homework. So I had not discussed here the treatment part. Last but not the least for today, a case of FTT with 5 months old was investigated, showing metabolic alkalosis, electrolyte were deranged, low potassium child was discharged after giving electrolyte correction. 4 years later, child had renal stone, was investigated and found to have hypercalciuria. What's the diagnosis? Tricky questions.
Sir, what is
VBG is a
FTT?
VBG is a venous blood gas. Huh? Sorry to.
Sir, what is FTT?
FTT is, I think, related, honestly speaking, FTT, I not have complete idea, but it is like a full term baby, something like that, with 5 months old, was investigated and venous blood gas was showing metabolic alkalosis. Yes.
So it's
So what?
failure to thrive, sir.
Yeah, it's
It's
a failure to
failure to
thrive.
thrive.
Failure.
Failure to
Fine.
thrive.
Fair enough. So this questions got it from Pedia anyway. So that's good. So failure to thrive. So
Right,
a case of
yes.
failure to thrive, 5 months. So now 5 months investigated. VBG venous blood gas was showing metabolic alkalosis, electrolyte were deranged, low potassium. All right. So and child was discharged after giving the electrolyte correction because electrolyte were low. 4 years later, child has a renal stone and found to have hypercalciuria. What it could be? Glitterman syndrome, CHPS, Bartter syndrome, Alport syndrome. So your homework. This is answer is Bartter. Now, but you need to know they ask three things. Write down in your notes. It's tricky, but frequently asked question. What is the difference between Gittelman, Bartter, and third thing is the Liddle, Liddle. Write down Liddle syndrome, Liddle. Go and little bit read it. It is one of the toxic questions in exam. So what is the Bartter and what is the Gittelman? So Bartter is an ascending loop of Henle. So you know ascending glomerulus, glomerular capsule, right? Then ascending loop of Henle and
Yeah.
descending, right? So you must keep in mind that picture. So this is a problem, location of the renal defect in Barter, sorry, not batter, Barter is a ascending loop of Henle and Gittelman, the difference is the distal tubule, not ascending. Second thing, urinary calcium excretion normal in Barter, right? Normal or increase. It's not always all right. And that is why increased urinary calcium, that is why nephrocalcinosis, which is there in our patient. Gittelman, it reduced. Serum concentration of magnesium, it is normal or diminished. Gittelman diminished. Renal production of prostaglandin E2 increase, it's normal. Usual age at presentation from birth. This patient has a failure to thrive and in early, right? Early presented before birth, from before birth to early childhood. This patient is in early childhood. And the Gittelman from the late childhood to adulthood. Our patient is very early present, again Barter. And neuromuscular symptoms infrequent or minor. And Gittelman's, it's very frequent, which is not mentioned here, the neuro muscular functions. So all in all, clubbing up the things, failure to thrive, ascending loop is involved, hypercalcinosis or calcium formation is developed. That is also there in the things, right? And presented in the early life and hypokalemia. So you can look into one chart. I did not have it here, but there is an excellent chart in the book where hypokalemia in neonate, how you differentiate between Lidl, how you differentiate Gittelman, and how you differentiate the Barter. So here the answer is Barter. Failure to thrive, metabolic alkalosis, right? Electrolyte always low potassium, right? After correction, again after 4 years, because hypercalciuria again goes in favor of Barter. So diagnosis is Barter. So you go and read the Barter, Gittelman, and third thing is a Lidl, Liddle, write down. Right. So these are the three things. So that's all. Thank you very much for today for your kind attention. We started at 12 and 1:30 Indian time. We stopped exactly in 1 hour 31 minutes. So let's give little quick feedback for 2 more minutes, if you don't mind. Please bear with me and stay with me. Those who have joined the first time, how was the experience, or how you explain this class? I mean, how did you enjoy?
So this is very, I'm Dr. Alia. This is very informative and very excellent, you know, knowledge. It's a very, worth class, I must say.
Thank you, Dania, for
Inshallah,
your
I will
kind.
be there.
Thank
Thank
you
you so
very
much.
much. Thank you, Dania. Thanks for your. Yes, anyone else? Anything you need, or
Me,
I mean,
Dr. Inga, would like to say it's excellent as always. It's absolutely informative, absolutely intelligent, and all of us, you will pass your exam with Dr. Munjal for sure.
thank you very much. Let me tell you, Dr. Inga is a Russian lady and she is a consultant in Dubai now. She is preparing for her PhD now. Recently, we got connected. She was one of my very early student in my coaching, probably more than 5 years or so. So she is still in contact, in touch, and she is preparing for further masters. So we again connected and she joined. Thank you very much, Inga, for your nice and kind words. Any feedback,
It's
Antara? I think I have
absolutely
seen you
useful.
just now. Thank you, Inga. I'll see you soon.
Thank you,
Probably.
Dr. Munjal. Thank you so much.
You're welcome. Yes,
I
Antara, any comment?
yeah, I like the way all the MCQs were discussed. I joined little late, but that's my loss. And because I am preparing after and I left studies few years back, so it's good sensitization and
Wonderful.
mind nurturing. Yeah,
Wonderful. So you will
it
get
should
a
be
lot of questions.
frequently. Yeah,
No,
yeah.
it is frequently. Next Sunday I will be in Dubai, but I will not skip the mock test. Don't worry. 22nd I will be in Dubai. Rather 20th I will reach, but I never miss the mock test. So 22nd, same time for last 1 year, I'm
Okay.
regularly taking. Very rarely I miss the mock test to take. So don't worry. 22 you can connect. Same time, Indian 12 to 1:30, 1.5 hour. Excellent brainstorming. And Monday to Saturday, our coach are coaching different subjects, surgery, medicine, gynec, pedia, blah blah. And they all are expert. All are expert. All are minimum MD and postgraduate. So they are brilliant speaker as well. So that's it. And any comment from Dr. Noor? Any comment lastly, if you want to give? Probably you are also first class today, Kanwal Noor. If you want to have some few words about the class, Dr. Rupali. Anyone? Any old one now? Then we'll pack up. What's something new to learn today? Probably you something learned today new, isn't it? Nothing like, I mean, almost 100% we knows, right? So something more fascinating to you, which you learned.
Sir, I confirmed my question query was there excisional biopsy and punch by that biopsy another tropic. There was the three option excisional, incisional, and one more is the
True cut.
true biopsy. So I had that doubt. So you clear it very nicely, and I think so. I will not forget at all.
Wonderful, wonderful. Rupali, Radhi,
Thank
any
you, sir.
comment last?
Hello,
Fine,
sir.
thank you.
Good morning.
Yes, please. Yes, please.
Wonderful
Good
class,
morning.
sir. Amazing. Amazing with our Dr. Pandya, sir. It's a mixed bag MCQ covered with few questions. We have covered a lot of subject and lot of topics. So thank you so much. It's my first class, but we are like connected from our previous years. But
Fair
it's a
enough.
wonderful and amazing experience, sir.
Thank you very much. Stay connected every Sunday with me. Same time, same platform, same everything. You get a link. Join our
Yes,
group so
sir.
you get all updates. Right? Post me.
Yes,
This is my
yes, sir.
number. Below feedback is my permanent number. It's there on the website as well. So stay connected. Thank you very much. So I'll just close this class and I'll upload this video on our YouTube channel as well. So if somebody missed, like Dr. Antara missed, you can catch on again our YouTube complete first line to last line. So you are not missed anything, Dr. Antara. So stay tuned, stay connected. Thank you very much and enjoy your
Thank you.
Sunday. Take care.